advantage of the DBS, like I said, it's not ablative, it doesn't burn tissue. You know, these are histology slides of what the brain looks like around an electrode. So it's reversible. You can turn it off. You can turn it on. You can take it out. It's titratable. You can program it. So it's a way to stimulate the brain reversibly and programmably. How does it work? We don't quite know, but more and more we think it's related to disrupting oscillations in the brain. It's almost like parts of the brain start firing too regular, okay, and that leads to tremor and problems with movement. So it's kind of similar like a pacemaker. You have part of the heart that starts firing. The pacemaker kind of resets the abnormal oscillations in the brain. So once again, we're thinking more and more about brain diseases as being kind of circuit disorders. The circuit starts firing, too regular. If you look at normal brains, sometimes it's not regular, but if you look at a brain in Parkinson's and you listen to the cells, they seem to fire very regularly. And DBS can disrupt that. That's why sometimes multiple targets work. If you kind of disrupt it anywhere in that target, anywhere in the circuit, you can kind of get a benefit. So there's not just one sweet spot. So let's go on a little bit more. And the most important part is selection. Like I said, there's no blood test you can do to say you're ready for DBS. It's a really big decision for families and patients. And once again, we don't mind seeing patients at any stage to start the conversation. It's a big deal to go through it, and it's a life-changing thing. And once again, we make our decisions very carefully. We don't just see a patient in the clinic and sign them up for brain surgery. So don't be afraid of coming to see us and talking about it, because it's a very complicated therapy, and you should be hearing it from a surgeon in a group that does it, and not necessarily from the neurologist who may have heard about it, or once again, we work as a multidisciplinary team. We meet, we talk about patients, we have kind of criteria. So once again, we want to make sure it's really Parkinson's disease. We like to traditionally wait about 5 years. Once again, you could do it sooner depending on symptoms, but sometimes in the early stages of Parkinson's, it's not quite clear if it's really Parkinson's, so sometimes we like to wait a while. Now when you talk to patients, a lot of times they'll say, you know what, even though I started medications 2 years ago, 5 years ago I was already having some trouble using my hand. So once again, a lot of times patients know they've developed the disease years before they actually get diagnosed. So the fluctuations I talked about, the cardinal motor symptoms, we don't want to have patients with dementia. Now, we don't just ask patients that or ask the family members. We make patients go through neuropsychological testing with a neuropsychologist. Dr. Schramke, she's a PhD. She spends a lot of time with patients and their families. She puts them through a lot of testing, but once again, it helps us to get an idea about whether a patient's going to be a good candidate or not. Some patients go towards DBS earlier because of side effects. Sometimes they don't feel good on medications. Sometimes they get terrible side effects from medications, including gambling problems, and once again, dopamine affects the reward pathways, and there's patients that sometimes get terrible side effects from these medications, and they don't tolerate them well. So they're looking for a non-medication treatment for their Parkinson's. So once again, our Allegheny kind of candidate screening, we do on-off testing, and Cindy Engel's here, and once again, she's been doing this for many years, and once again, we want to see how your motor score changes when you're on and you're off your medications. We want to see a certain amount of improvement. So once again, it's important that the medications are improving your symptoms. If they're not, then we're kind of suspicious that you might not really have Parkinson's disease. We do the neuropsychological testing. We want to see certain scores. We want to get an MRI of all our patients. We do the MRI with the patient asleep because we want to see the brain without any kind of movement. We use that for planning the surgery. And we want to make sure that there's no reason anatomically why you might not be a candidate. Like some patients if they've had a stroke or prior brain surgery, there might be a reason why they're not a candidate for structural. When to perform DBS? Now, this is a question that keeps, the target keeps changing. When DBS first came out, it was used for very late stage Parkinson's, 15, 20 years after diagnosis. Finally, they started doing trials of patients with kind of more earlier diagnosis. And there was an early STIM trial, and it really showed that doing DBS earlier improved quality of life and also reduced the cost of Parkinson's disease. So more and more we feel that doing it earlier is safer and beneficial. So if you're the best candidate, once again, younger
Dude, I
candidates.
didn't get my dinner.
Younger candidates will get more benefit.
Huh?
You have to respond to medications, tremor, rigidity, bradykinesia.
No, I'm done.
The motor symptoms are what we can fix the best. Now expectations are key as well. Once again, we tell all our patients this is not a cure. The disease will continue to progress. Our goal with the DBS is to make you look as good as you can and to, once again, along with medications, to improve the quality of life of patients. So once again, it's not a cure, but like I said, it's really the best treatment we have in addition to medication. So it's not an experimental treatment at this point. DBS for Parkinson's is well established. It's been done in tens of thousands of patients. So once again, we want to make sure your expectations are realistic. So if you come to us and say, you know what, I want a better cognition, that's not something we can do. If you want more fluid motions, if you want less tremor, if you want less rigidity, if you want less medications, these are things that are realistic expectations we can do. So we make sure that the expectations are reasonable. So how do we do the surgery? There's many different ways to do that. This surgery, people do it differently all over the country. Like I said, Dr. Whiting trained me and he's done many hundreds, and once again, we do it in 2 stages. So the stage 1, we still do awake. Once again, there are cases where we've done completely asleep, like if someone has really bad cervical dystonia or if someone's really too nervous to do it awake. But it's still kind of the gold standard from the FDA to do it awake. The reason is, if you do it awake, you can test it out. So the patient's awake, and they can move their arms and talk to you, and we can stimulate and we can test it when someone awakes. So once again, even though we have a lot of tools for imaging and still kind of a gold standard due to awake. Once again, we've done hundreds of cases at AGH. I can't remember one that a patient really couldn't tolerate it and we had to put them asleep in the middle of it. So it sounds scary, but truthfully, awake brain surgery is not new. I mean, people do awake brain surgery for tumors when they do much larger openings. We're making 2 quarter-sized holes in the brain. And once again, the brain itself doesn't have any pain fibers. It's not painful when you put the electrodes in. The worst part for most patients is putting the head frame on. And then when we drill, it's very loud, and patients feel like their teeth are chattering. But like I said, the rest of the surgery, the scalp is numbed up. Patients have often they ask questions during it. We listen to music. That's why I put the Frank Sinatra picture. But we let the patients pick the music because we think that kind of relaxes them. Our anesthesiologists are very careful to keep the blood pressure under control. But we do the first stage awake, and we call stage 1 placing the brain electrode. That takes a couple hours. The second stage we usually do about a week later, where we put you to sleep and we hook up with a wire the pacemaker battery. And you can have 2 batteries or 1 battery, with different systems. Again, it's not like one system will work and one system won't. There's different bells and whistles. We have experience with all the systems. We do research and kind of study these things. So once again, the most important thing is, are you a good candidate? And I don't want patients to worry much about the systems, and that's kind of, we work with all the companies and systems. The question is, are you a good candidate? Do you have realistic expectations? And, can we help you with this? Now, for a while we were sending all our patients to inpatient rehab. We don't do that as much anymore, but that is an option. So, overall it takes about a month to heal up. Once again, it's a pretty low risk surgery. I'll talk more about that, but like I said, of the surgery we do in the brain, it's one of the most least invasive surgeries. We're not retracting the brain. We're not, after you make those small holes, you cover them up with plastic caps. Those caps over the years have gotten less, 20 years ago they were kind of more prominent. All the technology's gotten a little bit more streamlined. So, once again, the targets in the brain, we usually use the target the STN. That's the subthalamic nucleus. It's a small, lens-shaped nucleus below the thalamus. The reason we target that is it's pretty easy to identify with our recording electrode called MER. We can listen to it and know we're in the right area. And it's the target that is best associated with reducing medication. Many patients come to us because they're taking meds 6 times a day, still having issues where as soon as their meds wear off, they're a mess and they're taking more. Many patients come to us, they really want to come down on the meds. Once again, shows a little bit about the anatomy. This is that subthalamic nucleus. This green thing here is what we're targeting. So we place the electrode past this target. We use microelectrode recording. Not all centers do this anymore, but once again, we still do it. Once again, there's like different areas of the brain fire with different electrical fingerprints. We pass a very small micro wire into the brain, and we listen to the cells. It helps us confirm that we're in the correct area of the brain. And it doesn't add too much time to the surgery, but once again, we use it to confirm. 20 years ago, when they first started doing DBS, they spent hours listening to the brain. Once again, and at this point, it's more of a confirmatory technique. So once again, postoperatively, we used to send patients to rehab and publish on this. Still an option, but we've been successful sending most patients home after stage 2 and programming them ourselves. So the programming is something that Cindy's been doing for how many years now? 20 years. So once again, she's programmed hundreds of patients. Amanda's here. She's our physician assistant that's also learning how to do this now. The programming is an art. So once again, these devices don't program themselves. Maybe someday they will. But just developing devices now that listen to the brain. Once again, right now you need a human being that looks at you, examines you, and programs you. The programming involves changing which contacts of those 4 are turned on, and which pulse width, the frequency of the electricity. There's tens of thousands of different flavors of electricity you can deliver. You can now, with directional electrodes, you can shape the electric field around these electrodes. Once again, the programming is an art, and it takes months to kind of find the best program for patients. So once again, usually what happens is after surgery, we wait a couple weeks, because sometimes just putting the electrodes in there causes a temporary effect. People say, oh, my tremor's better. I'm saying, we're not even turning it on yet. It's just because we're in that area. We let that micro effect kind of wear off, and we start programming. At the same time, we work with the neurologist to kind of start reducing medication. So as medications are coming down, we're cranking the electricity up, and over months, we try to find the best program for patients. But like I said, it's not like it's a programmable therapy. Patients may be happy for years and then need to be readjusted. So we keep following all our patients. Once again, it's a lifelong therapy. We continue to maintain it. And, there's papers published now that people have had DBS for 15, 20 years, and it's still working. It's not like it stops working. So you can't, once again, it still can provide benefit to patients 15, 20 years later. So it's pretty amazing. Once again, I talked about earlier DBS. More and more we think that, considering it earlier is better. Once again, obviously people are healthier, they're younger, they might not be on blood thinners. So in our opinion, if you're not happy with how you're doing with medications, you should come talk to us and kind of see what the option is. The risk of DBS are pretty low. Once again, we're a high volume center. We keep track of our outcomes. Once again, there's been big studies published across the country about high volume centers, but something catastrophic like a stroke or paralysis or death is very unlikely to happen from DBS. Seizures are unlikely, all kind of on the order of maybe 1% or 0.5%. So probably even less than that. The main complications that we've had are related to healing or infection. So once again, we keep kind of trying to get better about that, but like I said, if people get a wound healing problem or infection, they might have to have a washout or the hardware taken out. A lot of those patients, because DBS works so well for the Parkinson's, came back and 6 months later we put a whole new system. But once again, infections, the bane of all surgery, it's usually bacteria on your skin. We use powdered vancomycin. We have different techniques. We've changed the way we made our incisions recently in the last couple of years to try to reduce infection. But once again, some patients have diabetes, some patients have predispositions for infection, and something that will never be zero. But like I said, it's not a life-threatening problem if you get an infection, but it may require more surgery. So what improves? If you have tremor, actually, even if tremor doesn't respond well to medications, there's a good chance that we can get your tremor better. So rigidity improves, the slowness of movement, bradykinesia improves. Gait may or may not improve. Gait's kind of a complicated thing. So once again, some patients have gait because of postural instability. Their blood pressure may be different when they're standing. So once again, gait's kind of a mixed bag. Gait is a hard thing to improve necessarily with DBS, but in some patients it may improve. Now with dyskinesias, the patients are moving constantly. Some of these patients are moving so much that they can't maintain body weight. And we actually see them gain a little bit of weight after DBS because it slows their movement down. But the dyskinesias have a very high chance of improving with DBS. It's kind of a double whammy because DBS directly can reduce dyskinesias, but also by reducing your medications, you get those dyskinesias better. So patients with dyskinesias, DBS is an excellent thing. So once again, we're kind of beyond saying that it improves motor outcomes. We know that. It's been around for 20 years. More and more, the papers coming out are talking about quality of life. Does this improve quality of life? What else does it improve? Because obviously there's a lot of other things that Parkinson's affects. So more and more we're getting published data that DBS improves quality of life. This is in the highest kind of journals, New England Journal of Medicine. It improves emotional well-being, the stigma of having Parkinson's. These are things that maybe people didn't measure in the past with research. We just said, oh, the tremor's better, it's great. But once again, we're going back now, we're asking caretakers, we're asking spouses, we're asking family members. It's been shown to improve their quality of life too. The burden of taking care of someone with Parkinson's is immense, and DBS can improve on that. It's not just motor improvement. Quality of life can improve for caretakers. Once again, there's data that sleep can improve. We know a lot of our patients with Parkinson's have sleep disorders. Once again, it may improve the quality of sleep, the architecture of sleep, even pain. Pain's kind of one of these. I know a lot about pain because I treat chronic pain with stimulators in the spine. And I do a lot of back surgery. So pain's another one of my interests, but pain's probably one of the most under-recognized non-motor symptoms of Parkinson's. Many of our Parkinson's patients suffer from pain. It may be partially because dopamine's involved in pain and having depletion affects that, but the rigidity, the postural problems patients with Parkinson's have can cause severe pain, and DBS can improve pain as well in some patients. What's the future? Like I said, there used to be one company making DBS, and now there's multiple companies, so it's great. Competition is great. It's inspiring better technology for patients. We keep looking at new targets in the brain. We have better ways to visualize the white matter. So, like I said, this is called diffusion tensor imaging, but it's a way to look at the spaghetti, the actual white matter tracks in the brain, because that's what we think we're actually stimulating. So, once again, with improved imaging, we're hopefully finding better targets in the brain. Like I said, the leads keep improving. We have directional programming out. We have different generators. We have rechargeable, non-rechargeable generators. We're studying new modes of stimulation. We're partnering with Carnegie Mellon. There's a PhD there named Erin Giddis, and she also studies kind of mouse models of Parkinson's, and she's finding kind of new ways to stimulate, like new waveforms that might work better. So we're trying to translate that to humans. We've been doing image-guided programming where we're getting pictures of the brain after surgery program. There's more and more technology for remote programming. There's brain sensing coming out. Everyone's talking about the very future might be what's called closed loop, where the stimulator programs itself. So right now, we have to do it for you. This is our team here in the neurosurgery department. But like I said, our team's bigger because it involves the neurologist, Dr. Baser, Dr. Licklider. Once again, if you want a second opinion on your Parkinson's, see a movement disorder neurologist, because that's all they do. So like I said, and there's new drugs for Parkinson's every year. There's a lot of other therapies coming out. I think it's a very complicated disease to treat medically. So seeing someone that does that for a living, all they do is Parkinson's, you might get a better result or find something new. And once again, they also know about DBS. I think the movement disorder neurologist will have a better idea of if you'll be a good candidate for DBS. This is the frame we use. Like I said, we numb you up in 4 spots, and we put a frame on your head. There are frameless ways to do DBS. Like I said, it's still kind of the gold standard. When we put that frame on, our accuracy should be even below a millimeter when we're putting electrodes in. So, like I said, that's still kind of the gold standard that we do for DBS. And like I said, Dr. Whiting and Cindy here training how to do this, so it's worked well for them. So what's the conclusions? The DBS is very safe. It's a well-established therapy. Like I said, it's not new. It's not an experimental treatment. It shouldn't be considered as a last resort. A lot of patients keep saying, you know, I'll do DBS when the medications don't work. That's not the time to do DBS. You should do DBS earlier when your symptoms aren't being that well controlled with medication. So once again, I think if you're getting fluctuations, if you think you're progressing despite medications, it may be time to consider. Once again, it takes you know, it's not like a one appointment you show up and we sign you up for brain surgery. We get to know you, get to know the family. We do a lot of testing to see if you're a good candidate. So it's a process. And like I said, we don't mind seeing patients earlier because it's a complex therapy. And once again, a lot of patients, a lot of neurologists really don't know if they're a candidate or not. So it really remains underutilized. We don't do it enough. Once again, why is that? Like I said, maybe some patients are afraid of brain surgery. Some patients don't know if they're a candidate. Some people think, you know, they keep thinking that they're not bad enough for it, or so once again, it's something that, you know, by reaching out to patients, we hope to see more patients and to talk about it, and hopefully we can help more people. All right, I've talked enough. What questions do you guys have?
You mentioned that it's mainly for idiopathic Parkinson's. What about the Parkinson's that may come from chemical exposure, that sort of thing?
That's a good question. So it can help kind of secondary Parkinson's or Parkinson's plus, but it's not, you know, it may not be as helpful in those diseases. So I think it's kind of, you know, we may consider it. We've done it before for different, you know, kind of Parkinson's-like syndromes, but it may not work as well. So once again, you know, it's all about quality of life. If someone comes in and they have Parkinson's from, like I said, you know, there was cases about 15 years ago where some young men in California took a street drug called MPTP, and they thought it was kind of like they thought it was going to be like a methamphetamine kind of street drug, but it ended up causing Parkinson's, and it caused damage to part of their basal ganglia. And some of these patients have actually been treated with DBS successfully, and they actually used that drug to create the animal models in primates. So once again, it helped us learn about the disease in DBS, but once again, you know, there's publications of it, you know, for many different diseases that are similar to Parkinson's, even Huntington's and some other neurodegenerative disorders. But once again, you know, the best outcomes that we can, you know, when we talk to patients about what can you expect, you know, our best outcomes are with what we call idiopathic Parkinson's. Yes.
I have to deal with old timers, you know, brain injury and Parkinson's. I read a lot about Dale Bredesen. He's a neurosurgeon and a researcher for Parkinson's, and they characterize Parkinson's number 1, number 2, and number 3, and got different protocol for each one. But you were mentioning about mold before, when you were talking
About
mold. Toxins,
toxins,
bacteria.
yeah.
One of them is just, I mean, other than the other stuff that contributes, basically it's that gives you.
Like I said, there's a lot of papers written about risk factors. It seems to be more prevalent in rural areas. There's definitely some associations with pesticides. There's definitely some, like well water increases risk.
A lot of people around this area live on top of mines and stuff like that. And like I know at my house I do. I have to worry about that every year. And it's a big contributor to a lot of stuff. And by the way, if I ever lay down on one of your tables and Frank is singing, I want to be, when I was 17, it was a very good year. involved for you.
Any other questions? Yes.
And what was that about someone had a stroke in the past?
Yeah, so we get an MRI in all the patients before surgery. Once again, if it's a very large stroke, that might affect the brain where we do the surgery, so that might be a reason that we can't do it. But a small stroke would not necessarily be a reason you can't have the DBS. So once again, that's, it's pretty rare, but once again, if someone's had a very large stroke, that's affected like half the brain, and there's, atrophy from that stroke, that might be a case where we don't do DBS. Yes.
What age is best to have that done? Go to do it.
Yeah, so once again, it's, we've done patients, younger patients, in their 40s with Parkinson's disease. Like I said, there's no really age cutoff. I think it depends on, the patient's quality of life and functioning. And, I think more and more we think that, if you do it when you're younger, you get more benefit because potentially you can come down on the meds. And you also tend to be healthier and heal better. And like I said, sometimes when patients are older, they have heart problems, they may be just higher risk for surgery. So once again, I think more and more the needle's moving to do it earlier in the disease. So if someone's doing great on meds, we wouldn't consider it. But if someone, despite medications, is still, having tremor, breakthrough, fluctuations, if people are having side effects from medications, you might consider it earlier. So it's like I said, there's no standardized guidelines exactly to tell you when's the right time to do it. That's why we kind of meet with you and decide what, some people don't like the way they feel on meds, some people don't like, it depends what you want to do. I think we can't say that DBS stops the progression of disease. It continues to progress. The only thing that might stop progression is exercise. And once again, we work closely with our physical therapist. Dr. Licklider is involved in the Cowit Center, which brings kind of physical therapy to you and speech therapy. And once again, we try to get the patients active and moving, and because once again, that's very important to stop the progression.
How long on average does it take for your system to be programmed properly?
Did you say 6 months?
I mean,
I'm going to defer to Cindy here.
Essential tremor is relatively easy, more defined, so probably within 2 or 3 visits.
okay.
Parkinson's, it's a little longer to get through the work that you do some the meds, so it could be 2 or 3 months.
So how do you decide if it's not Parkinson's, like someone that just has essential tremors or Tourette syndrome? Like how do you determine whether they'd benefit from it?
Well, like I said, the essential tremor, DBS works very well for as well. It's a different type of tremor. It's more of an action tremor. So once again, we can often tell that on examination. And those patients don't tend to have rigidity. Once again, part of it's the clinical exam. Some of these patients, they try on medications like Cinemet and it doesn't have any effect. So once again, it's something that, we really work closely with our neurologist, and, we meet as a group, and it's, once again, we talk about patients, if we think they're a good candidate or not. And I mean, there is some overlap. There are some patients that kind of have essential type tremor, but they end up developing Parkinson's within years. And but once again, both the essential tremor and the Parkinson's diseases are good candidates. Yes.
So the genetic component, is it like a haplogroup or autosomal group that's more susceptible?
Yeah, that's a good question. So there's certain genes like the KKR I talked about, single genes that are associated with it. We're not at the point where we're kind of screening all patients genetically. We've talked about doing that. So I think once again, that's kind of maybe the future of medicine where every single patient gets a whole genetic profile. Right now, I think if we have a family association, like a couple family members, then we can kind of maybe justify the cost of doing the genetic testing, but we don't do it for all our patients. But it's, we'd love to. I'd love if every single patient got genetic testing because we could learn some things about that, but it's still too expensive to do that.
I have another question.
Oh.
How do you decide, was there someone else?
Sorry,
if you have DBS, can you have a pacemaker?
Yes, question is, if you have DBS, can you have a pacemaker? Absolutely, yeah. We have a lot of patients who have DBS. They have a DBS battery here, and they have a pacemaker battery here, or vice versa. So, once again, having a pacemaker doesn't keep you from getting DBS. We might do it a little bit differently. We might get a CT scan instead of an MRI, but we have patients with both, so. Yeah.
How do you decide which system that you use?
That's a great question. So,
It was easy years ago.
it's talk to the patients about the systems. We give them handouts, and we kind of talk to them about it. And once again, I think there's a lot of every system has different bells and whistles. They all work. It's not like one system's going to work. I tell patients one won't work. So if you have Parkinson's and you're a good candidate, any of the systems will work. Once again, there's differences in rechargeability. If you want to have a battery you have to charge versus one you don't have to charge. And that's kind of the main determinant right now that's driving probably patient decisions. So once again, that's surgically it doesn't change what I do the systems much. So there's not like one system that's lower risk for brain surgery than another system. So they're all copying each other. They're all pretty much similar for the most part in the basic hardware aspect. So like I said, it's something that that's not, like I said, I let patients kind of decide that personally. I don't, once again, I like, if they want a certain system, if they think that would be better for them, if their neurologist has a very strong preference for some system, and it's going to be involved programming, maybe that's fine with that. I mean, I think it's, once again, our main thing is to find the good candidates. Okay, because if you find good candidates, all the systems will work. The system from 20 years ago will work for a good candidate. But it's improved. I mean, like I said, a lot of stuff, they've all improved, which is nice. I mean, really, for 20, when it first came out, there was just one system, and we kept saying, can you make it less bulky and this? And once again, when you have a monopoly, you don't get improvement. So now that you have multiple companies designing, competing for patients, and it's pushed the bar up. So it's a good thing.
Are all the medical and health care providers on the same page?
Good question. Yes, I mean it's we occasionally get like a denial, but we call people and we educate them that DBS has been around for a while. Once again, this is not something that your insurance should give you a hard time for. This is
Well, here you worry about AHN and you worry about your PMC. Are they working together?
Yeah. All the insurances will pay for DBS. This is not some insurances won't. So you don't
Well, see, that is the first step to having quality of life. Is where it don't matter where you go, you get the same people doing the best for you.
They'll all pay for the surgery. Where you can have it done is still sometimes controlled by the insurance. So I may not be able to do it if you have a certain insurance, but you can still get DBS. So once again, if we have someone that's a good candidate, but we can't do it, we'll find someone that can do it for you in the city. But the insurance will pay for it. It's not, but they might decide, hey, you have to have it at this place or this way.
Well, I like the quality of life thing. There ain't no sense in you even be here if you don't have it.
I was surprised when I was diagnosed that there's not any definitive tests or anything to determine for sure that you have one.
Yeah, that's.
And I understand based on what causes it. But has there been any research or movement towards something to be more definitive?
That's a good question. So once again, there's no blood test that we can do right now to say you have Parkinson's disease. It's still a clinical diagnosis. Some of the imaging has improved. There's scans of dopamine transporters that can show depletion that can support the diagnosis. They're not specific for Parkinson's, but they can help support the diagnosis if it's kind of not quite clear. But yeah, we don't have a blood test that we can say you have Parkinson's. So once again, it's still a clinical diagnosis. It's based on your symptoms and your response to medications. It's something that, once again, had patients that were told they had Parkinson's, they were diagnosed by their primary care doctor that we saw and we evaluated and said, we don't really think you have Parkinson's. And so once again, I think that's why we don't rush to do the surgery unless we're pretty confident with the diagnosis. Even neurologists in the community might not be as confident about diagnosis. Maybe we'll involve our movement disorder neurologist for a second opinion. But once again, the diagnosis has to be, ideally made by someone that knows a lot about Parkinson's and knows about the kind of the similar other diseases. So. Yes.
So my mother has had Parkinson's for almost 30 years. She got DBS almost 20 years ago. I have to say it completely changed her life, our whole family's life, and it was incredible. They said when she was talking with doctors at the time that if she didn't get this procedure, she would likely be in a wheelchair in 6 months. And she got the procedure. She actually had a complication, and then she had a bleed in the brain through the surgery, and then they had to stop it, which was a very low percentage chance, but it can happen. But she wanted it so bad, and she needed this for her, for her life to change, that she went back and was able to get it a few months later once everything was recovered. But I will say it was still worth it, and I think that if it really does feel right for you, it can make a huge difference in your life. And there are all these tests to go through to make sure that you're the right candidate, but that's because it's a big deal, but it can really change your life. And 20 years later, her disease has progressed, but it gave her years of mobility back that she wouldn't have had. So that's my first thing. It's a really incredible surgery, and my mother is living proof that it's great. It's not for everyone, but it really is life-changing. And second, I had a question because when she got hers done, the battery life was very short, and she still has to get it replaced every 2 years, which is not ideal. But I wondered, if you have an older system, can you get newer batteries?
She must have them in stock.
Yeah.
She can get a rechargeable.
Yeah.
Yeah?
She could get a rechargeable now, which could last 10 years. So, definitely there's options to convert to that. So that's definitely a consideration. That's why and we talk about this when we talk about the different systems and what once again there's patients that one system fits better for their lifestyle than others. So once again, I think it's nice that we have options, and once again we keep trying to do research and study these things and how patients are doing, and but these are obviously important things to patients, how often they're going to have surgery for maintenance. Even if it's a small surgery, it's they have to come in. Sometimes patients live a distance away, and it's a nuisance to have to potentially replace the battery in this. And once again, there may be other maintenance if they break a wire in the neck and stuff like that. So there's maintenance surgeries that come up sometimes. But yeah, I mean, of the things I get to do in neurosurgery, it's definitely one of the most gratifying things. It can be life changing for patients. I think patients, when it works well, they're so thankful, and I think we've told these patients for years, and it's exciting to see that it still can keep working for a long time. I mean, there's not many things that work. I mean, cars don't work for 20 years, but we have patients with the same wires that are still working 20 years later, which is pretty cool. So it's pretty impressive. Even the old stuff sometimes has been amazingly durable. So once again, it's gotten better, but like I said, it was pretty amazing. It started in France. Dr. Benabid was the neurosurgeon that did the first DBS in France in Grenoble, and like I said, it's taken off. And I'm fortunate to have been in Pittsburgh because, like I said, Dr. Whiting has been a major implanter and does research. And like I said, it's something that we love doing. I think Parkinson's is well established, and we don't do enough of it, but we think it's going to help other diseases as well. So.
Is the surgery always bilateral?
Good question. Pretty much we've done it bilateral because we found that you just get better control of the disease, better crosstalk. when essential tremor was done, when it first came out, you know, the FDA indication was actually for unilateral. But even in those patients, we kind of went to primarily doing it bilateral, because what would happen is someone would start out with tremor in one arm, and then it would spread, and then they have to go back for another brain surgery. And I think we found that when you're doing it, you're in the frame, it's better just to do 20, 30 more minutes to the other side. And you know, if you don't have to use it as much programming wise, you don't have to, but you have it there, because we know that these diseases, including essential tremor, will progress, and we found that bilateral is a better option for patients. You know, I don't think patients would want to go back for another side necessarily, but.
Can you replace the habit of the Medtronic, an habit if the Medtronic is old enough?
You know, these systems can be sometimes swapped and combined, and the downside of that hybridization is that you kind of lose the ability to maybe get MRIs. But once again, you know, we've looked into that. We've been doing some research on our own about kind of mixing technologies. So once again, something that we can talk to you about. But yeah, I mean, there's options to consider doing that for patients. You know, I think there's pros and cons to doing that. But maybe getting more battery life would be a reason to do that. Maybe giving someone rechargeability would be a reason to do that. So once again, it's something that is being done, and there's some research behind it. But you know, it depends. It depends, you know, when the leads were done, if they're compatible and stuff like that. So we have to look into the model number and all this stuff like that. But we have done that in some cases. Yes.
If somebody wants to come talk to you more about DBS, what is the best way for somebody to make an appointment, or how do you want people doing that?
Cindy has some cards, and Cindy is the gatekeeper. So, I mean, we would like the patient to kind of, you know, go through Cindy and Amanda and come to what we would call our kind of movement disorder clinic, which they primarily run. And like I said, I usually kind of run concurrently a clinic. But once again, you know, it's a process. Like I said, we want to get to know a patient, kind of find out what neurologist has been managing them, is the diagnosis. And sometimes patients come, they don't have a neurologist, they're being managed by a primary doctor. We might get them a neurologist, and then once again start, you know, it's a lot to kind of go through, and you know, the process. You know, we often see patients who are deciding about it, and at some point they decide that it's time to do it, and get to know the families and what their expectations are, and what, you know, once again, it's a process, but we get to know these patients very well, and we continue to follow. You know, once you have DBS, you're kind of stuck with us. So, you know, most of our patients we do program, and we, you know, once again, there are neurologists that are doing some programming in this region, but most neurologists really haven't kind of, you know, shown a great passion of, you know, learning the complexity of programming and the different systems, and that's why we've kind of maintained that.
I noticed one thing that you said that really amazed me was if medicine's not working, what's the protocol then? I mean, what's the procedure that you go through with your doctor or whatever?
Well, part of it's kind of looking at, you know, maybe, you know, talking with our movement disorder neurologist, seeing what medicines they've tried. You know, is there something that's worth still trying or not, or, you know, was the medicine not working because of side effects, or was it causing it, you know? So I think, once again, it's something that, it's a very complex disease. You know, everyone's Parkinson's is a little bit different. So, you know, part of our, you know, evaluation is to kind of learn about what symptoms are causing the most problems, and what, you know, what people expect. Like I said, if people's main problem is they have trouble swallowing, that's not something that we would rush to do DBS for.
Right.
Now, there may be a couple publications that it helps that, but that's not kind of the main thing that we do. You know, once again, if people come in and their main symptom is that they're freezing up and having tremor, that's the kind of patient we say, listen,
Well, there's more than dopa, right? More medicine?
Oh yeah, there's a lot of medicines.
Okay. Well, I was under the impression that if it didn't work for me, which it didn't,
Yeah.
then I was not going to be able to just stop.
Yeah.
Of course, I go to Kaufman Center.
Okay.
Okay? And I did. I work out 2.5 hours a day, and I couldn't on it. I mean, I had to do that for 40 years, or I wouldn't be where I am today. Okay, I fell 32 feet and landed on my head. Took me a few years to wrap my head around the fact that if I didn't look out for number one, I was gonna step in number two. So I had to develop that, you know, and even at 74, I could still do it. But ever since I took the dopa,
Yeah.
it wasn't that I couldn't do as much. And if I spread it all out, you know, I'm pretty aggressive when I do, just take my time. I felt like crap after I did it. I mean, it made me feel worse than the Parkinson's.
That's what we hear sometimes. Like I said, some patients just don't do well with the meds from a side effect standpoint. They don't like the way they feel. They're wired. They don't sleep well. Once again, they may even get, you know, we've had patients that, you know, once again, they start online gambling and start kind of losing their house. I mean, they start acting like different people. Their personality changes. So there's reasons that they say, I just want to come off of some of these meds. Is there another? So that's the kind of patient we would consider. Yes.
If you have a different physician other than your group, do they have to come in through your doctors then, rather than your own physician?
No, you can come in without just by self-referral. I mean, you don't have to have, you know, once again, it doesn't matter who your doctor is, you can come see us.
Because he follows through with the neurologist.
Yeah.
So just go into a program would be through your physicians, you know, primarily.
Yeah, that'd be fine. I mean, we can work with his neurologist. He doesn't have to be part of our group. So once again, it's not a requirement that our neurologists are involved. So once again, we have patients from Altoona and Erie and who have neurologists that are, you know, once again, it doesn't have to be one of our neurologists managing you at all. So, and we'll work with your neurologist. Once again, most of the neurologists are happy if we kind of manage the DBS and do the programming. But we do have some neurologists across the state that do programming and once again, want to do that part of it. So once again, but in most cases, we do the programming and that's worked out well for us. All right. Any other questions? Thanks for coming out. Hope that was helpful.
Thank you.